Hello, everyone. Welcome and happy National Minority Health Month. Thank you to everyone who has joined us for our Better Health Through Better Understanding, Promoting Health Equity and Culturally and Linguistically Appropriate Services, or CLAS webinar, including our wonderful panelists. My name is Juliette Bowie. I'm the Director of the Division of Policy and Data in the Office of Minority Health at the U.S. Department of Health and Human Services. And I'm so pleased to be your moderator for today's webinar. The opinions expressed by speakers during this event are strictly their own, and they do not necessarily represent the views of or imply endorsement by the Office of the Assistant Secretary for Health, the Office of Minority Health, and the Department of Health and Human Services. Before I launch into these learning objectives, just a few housekeeping items. This webinar is being recorded and will also be posted to the OMH YouTube channel. All participants will be automatically muted throughout the duration of this webinar. We will have time for questions after our last presentation, but please feel free to submit your questions at any point during the webinar via the chat box, and we'll try to answer as many questions as possible. This webinar aims to increase awareness and implementation of approaches for applying the national CLAS standards. So today's speakers will highlight current federal efforts addressing cultural competency and class in healthcare as a strategy to reduce health disparities. And today's presentation will also highlight a local government effort in advancing culturally appropriate health literacy strategies to enhance COVID-19 testing, contact tracing, and other mitigation measures in racial and ethnic minority populations and other socially vulnerable populations. I went over these points already. So to help frame today's webinar, I'd like to start by providing some context for CLAS as a strategy to reduce health disparities and advance health equity, and by sharing OMH resources related to CLAS. At OMH, we define CLAS as services that are respectful of and responsive to individual cultural health beliefs and practices, preferred languages, health literacy levels, and communication needs, and employed by all members of an organization, regardless of size, at every point of contact. So CLAS really centers the individual, and individuals' beliefs, preferences, and communication needs should really shape how we think about and deliver health and healthcare services rather than a one-size-fits-all approach. And providing CLAS requires an all-in approach by everyone at an organization and by any organization or system that might influence health and well-being. By providing CLAS, meaning respecting the whole individual and responding to the individual's health needs and preferences, we can improve access to care and improve the quality of services provided to all individuals, which will ultimately help reduce health disparities and achieve health equity. And we see this through a number of outcomes from providing CLAS, like improved engagement and communication, the increased use of services, and increased adherence to treatment. So as you know, throughout this pandemic, some communities are being disproportionately impacted by COVID-19. And the lack of CLAS has really played a role in contributing to these barriers and poor outcomes. So CLAS is particularly important for health equity in the context of the pandemic, but also beyond, especially in light of the barriers that some populations have faced historically. To help operationalize CLAS, OMH developed the national standards for culturally and linguistically appropriate services in health and healthcare, or the national CLAS standards. The original standards were released in 2000 and enhanced standards were released in 2013. There are 15 standards, each of which is an action step that guides professionals and organizations in providing services that are respectful, understandable, effective, and equitable. We promote collective adoption of all of the standards, viewing each standard as an equally important guideline. The standards are structured to include a principal standard that serves as a foundation for all the other standards. And aligned with the CLAS definition I shared earlier, the principal standard is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. And the rest of the standards fall under 3 themes. The first theme is governance, leadership, and workforce. And this theme emphasizes that implementing CLAS is the responsibility of the entire health system, and that requires the investment, support, and training of all individuals within an organization. The second theme, communication and language assistance, encompasses all those communication needs and services, inclusive of languages other than English, sign language, Braille, oral interpretation, and written translation. And finally, engagement, continuous improvement, and accountability focuses on those supports that are necessary for the adoption, implementation, and maintenance of culturally and linguistically appropriate policies and services. So you can really see that it's not just limited to language assistance, but really a comprehensive approach that takes into account the breadth of actions that we need to fully provide and sustain CLAS. OMH offers a number of resources that I invite you to check out to learn more about the national CLAS standards and how to provide CLAS. Think Cultural Health is our website that houses resources for individuals and organizations to build capacity around understanding cultural and linguistic competency and implementing the national CLAS standards. And through Think Cultural Health, we offer a suite of free e-learning programs for a number of types of health professionals. These e-learning programs are grounded in the national CLAS standards. They're interactive and self-paced, and they're also accredited, so you can earn continuing education units by completing the programs. We offer some other resources that support implementation of the national CLAS standards, including an implementation checklist. We have a blueprint for advancing CLAS policy and practice, and also a behavioral health implementation guide. And these 2 documents go into deeper detail about concrete strategies aligned with the standards. And there's also an evaluation toolkit for organizations to assess their implementation of the CLAS standards. So again, I invite you to visit the Think Cultural Health website to check out our e-learning programs and resources, and to share these resources with your networks and partners. You'll hear a lot more about other resources and efforts to provide CLAS from our wonderful presenters today. So with that, it's my honor to introduce our first presenter, Dr. LaShawn McEver, who is the Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services. Dr. McEver joined CMS as the Director of the Office of Minority Health in August 2020. She's a proven public health leader with experience in driving successful health initiatives and public policy efforts aimed at promoting health equity, improving health outcomes, increasing access to care, and promoting health system reform. Dr. McEver earned a medical degree in international health and medicine through the Medical School for International Health in collaboration with Columbia University's Medical Center, and a master's degree of public health from Johns Hopkins University Bloomberg School of Public Health. So thank you so much for joining us today, Dr. McEver.
Thank you, Juliet, for that introduction. Hello, everyone. I'm delighted to be joining you all for today's webinar to discuss promoting health equity and culturally and linguistically appropriate resources and services. As noted, my name is Dr. LaShawn McEver, and I'm the Director of the Centers for Medicare and Medicaid Services Office of Minority Health, or CMS OMH. Within this role, I work to ensure CMS is focused on meeting the needs of medically underserved populations as we work to advance health equity throughout CMS's programs, policies, and partnerships. Next slide, please. For my portion of the session today, I will begin by introducing the role of CMS's Office of Minority Health in more detail and provide an overview of how we're implementing the national CLAS standards across CMS. I will share with you some policy, data, and programmatic examples of how we're working to implement the national class standards and taking actions that promote delivery of culturally and linguistically appropriate care for every person we serve across Medicare, Medicaid, the Children's Health Insurance Program, and the marketplace. Next slide. So I'm going to begin with an overview of CMS OMH. Next slide. As many of you know, CMS is the largest provider of health insurance in the United States. Our agency is responsible for ensuring that more than 150 million individuals are able to get the care and health coverage they need and deserve to live a healthy life. Our office, the CMS Office of Minority Health, is one of 8 minority health offices within the larger Department of Health and Human Services. Within CMS, we serve as the principal advisor to the entire CMS agency on the needs of minority and medically underserved populations, including people from racial and ethnic communities, people with limited English proficiency, lesbian, gay, bisexual, transgender, and queer persons, persons with disabilities, persons who live in rural and geographically isolated areas, and persons otherwise adversely affected by persistent poverty or inequity. On this slide, we have listed our office's mission and vision statements. And given our role within the healthcare system, it is vitally important that CMS works to ensure each person we serve is able to access the services that meets their needs when and where they need care and coverage, and that those services are geographically available, physically accessible, culturally and linguistically tailored, with communication at appropriate literacy levels, so that all people can achieve their highest level of health and well-being. Next slide. In 2022, CMS released its Health Equity Framework. This evidence-based, stakeholder-informed framework serves as a guide for the agency as we work to address the needs of medically underserved communities. The 5 priority areas included in the framework for health equity are listed here on the slide. The first priority area is expanding the collection, reporting, and analysis of standardized data. The second priority area is assessing causes of disparities within CMS programs and addressing inequities in policies and operations to close gaps. The third priority area is building capacity of healthcare organizations and the workforce to reduce health and healthcare disparities. And our focus today is our fourth priority area, advancing language access, health literacy, and the provision of culturally tailored services. And lastly, our fifth priority area is increasing all forms of accessibility to healthcare services and coverage. Next slide. So what are some of the actions that CMS is taking to implement the national class standards? Next slide. As we think about the national class standards, as noted, CMS has a vital role to play related to each of the 15 national class standards described earlier. We are taking action within CMS in 3 key areas. So in our policy, programs, and data efforts, in our engagement with community collaborators and external partners, and at an agency-wide level in strategic thinking and planning. Next slide. CMS is taking actions across our programs to ensure our regulations and requirements promote delivery of culturally and linguistically appropriate care. One significant example of this, just released this month, is the 2024 Medicare Advantage and Part D final regulation. This regulation has a number of provisions related to cultural competence. So for example, CMS is clarifying current rules, expanding the example list of populations that MA organizations must provide services in a culturally competent manner. So for example, people with limited English proficiency or reading skills, those belonging to various ethnic, cultural, racial, or religious minorities, people with disabilities, and just to name a few. So I'll just name those few. In addition, studies demonstrate low digital health literacy, especially among populations experiencing health disparities, continue to impede telehealth access and worsen care gaps, particularly among older adults. CMS is finalizing requirements for MA organizations to develop and maintain procedures to offer digital health education to enrollees to improve access to medically necessary covered telehealth benefits. We're also enhancing current best practices by requiring MA organizations to include providers' cultural and linguistic capabilities in provider directories. This change will improve the quality and usability of provider directories, particularly for non-English speakers, limited English proficient individuals, and enrollees who use American Sign Language. Additionally, CMS is requiring that MA organizations' quality improvement programs include efforts to reduce disparities. We hope, taken together, these provisions significantly strengthen the provision of culturally and linguistically appropriate care among Medicare Advantage plans. Another example related to CMS's data efforts is our work to understand and identify the needs of enrollees in our Medicare program. Through the Medicare Current Beneficiary Survey, or MCBS, we asked several questions related to cultural and linguistic competence to better understand what our programs and healthcare professionals need to do their best to serve our enrollees. So for example, we have questions and we analyze data related to languages spoken at home, whether someone speaks or reads English very well or not at all, whether individuals have difficulty seeing or hearing, and to the extent to which individuals are able to find needed healthcare information and communicate with their providers. This information allows us to continue to improve our programs to provide the safest, highest quality care for all those we serve. These are limited examples and relate just to the Medicare program, but across CMS, we have many examples of how we are doing this work in the Marketplace, Medicaid, and the Children's Health Insurance Program. So I encourage you to explore the CMS blog for some posts on our most recent regulations, many of which have a section related to health equity that describes some key provisions promoting culturally and linguistically tailored care in other CMS programs. Next slide. Outside of policy and programs, we also have public-facing resources, training modules, educational content, and toolkits and resources for community collaborators and CMS partners that promote delivery of culturally and linguistically tailored services. This slide includes a few examples. In the Marketplace, our training for assisters includes a module on delivering culturally and linguistically tailored assister support as individuals find and enroll in the Marketplace plan that is right for them. Our Medicare Learning Network hosts several trainings free of charge for all healthcare professionals, including those related to promoting delivery of linguistically tailored services and language access to healthcare services, as well as trainings related to ensuring that care meets the needs of individuals with disabilities and members of the LGBTQI+ community. Our Federal Coordinated Healthcare Office hosts a hub for resources for integrated care with information, resources, and training content that promotes delivery of culturally and linguistically tailored long-term services and supports and caregiver supports. And last but not least, the CMS Office of Minority Health, we have several resources on our quality improvement resource page and our Coverage to Care initiative, which aim to help healthcare professionals and community partners deliver culturally and linguistically tailored care and communicate at all literacy levels to all communities. Next slide. Finally, and critically important, we recognize that as an agency, we must understand and implement the national CLAS standards and language access related policies and programs at an enterprise level to ensure it is a part of our strategic thinking and forward planning. To this end, we have been working to pull our activities together across the agency so that we have an agency-wide picture of what we are doing across our programs to implement the national CLAS standards as a part of the work of our internal advisory council on equity and our policy work group, the Policy Collaborative. We are also working as an agency to implement and update our CMS language access plan, aligned with updated regulations related to Section 1557 of the Affordable Care Act when they are released. So these agency-wide plans and our agency-wide approach to delivering culturally and linguistically tailored care across all of our programs helps us align our actions with the department and within CMS to think strategically together to ensure we are collaborating, working proactively, and ultimately delivering the best, most accessible, and appropriate care to each person our agency serves. It has been an honor and a pleasure to discuss with you all today how CMS is prioritizing the national class standards. If anyone would like to get in contact with us or receive any additional information, here are all the avenues in which you can contact CMS's Office of Minority Health. You can email us directly at omh.cms.hhs.gov. And again, listed here are all the ways that we can hopefully be of support. Thank you, Nessa. That was the next slide. So thank you, and I look forward to hearing from my fellow presenters. Thank you.
Thank you so much, Dr. McGeever, for your great presentation and for the leadership of you and your office on these efforts. It's now my pleasure to introduce our next presenter, who is BC Nguyen from the Office of Health Equity in the New Mexico Department of Health. BC is a training and access coordinator working with diverse communities to advance health equity at the New Mexico Department of Health. She grew up in the Mekong Delta in Vietnam and traveled extensively before settling in Santa Fe, New Mexico in 2020. Her passion lies in bringing people together for conversations in social justice and helping people stay in those conversations. So thanks for joining us, BC.
Thank you, Juliet. Hi, everyone. My name is BC and pronouns she, her. And I'm speaking to you from the land of New Mexico. On behalf of all of my colleagues, I humbly acknowledge we are on unceded ancestral lands of the original peoples of the Apache, Navajo, and Pueblo, past and present. It's my honor to be here sharing about actions to sustain class standards in New Mexico and learning from esteemed colleagues here and everyone in the audience, and from federal offices and in other states. Thank you all for being here. I was born and raised in post-war Vietnam, and knowing the human cost of war and violence, what my parents always wanted was to have peace, so that they could go to work, travel, and grow a family. As a young adult, I was inspired by the work of the activists during the early years of the HIV/AIDS epidemic in America. They have fought hard to transform a political climate that dehumanized and denied basic healthcare, research funding, and critical intervention to a group of citizens. So they have transformed that into what is happening now. Folks with HIV/AIDS can receive public funding for healthcare and services so that everyone can go to work, travel, and grow a family. So my upbringing and these social justice movements guide me in my work as an employee at the New Mexico Department of Health. And I'm excited that we are at one of the more exciting thresholds in the health equity conversations happening here at state level as well as federal level. So New Mexico is a diverse and multiracial state, and 6 out of 10 New Mexico residents are people of color. Nearly 1 in 10 New Mexico residents is an immigrant. Around 35% of New Mexicans are multilingual. So you can see here the strategy on the screen of strength-based dual language communication in all of our department's public messages. Public health orders during the height of the pandemic are translated into Spanish, into Diné, which is the Navajo Nation's language, and Vietnamese. We co-hosted vaccine confidence town halls with our community partners in many languages. We, for example, did not assume that Asian American community is one homogeneous race. We offer Korean, Tagalog, Vietnamese, Mandarin, Cantonese, and Khmer simultaneous interpreting together with ASL, like we are doing here, which is great. This aligns with CLAS standards regarding the provision of effective, equitable, understandable, and respectful services that are responsive to diverse cultural health beliefs and practices and communications needs. Our community health workers, promotores, and tribal liaisons are based in communities, and they can speak with respect and humility towards indigenous systems of knowledge, acknowledging spirituality alongside physical and mental health. These communication practices, habit, values are sustained because our leaders at New Mexico Department of Health recognize that structural racism reinforces ways to perpetuate racial group inequity for people of color, including indigenous peoples and tribes, pueblos, and nations. We recognize that structural racism results in poverty, power imbalances, discrimination, lack of quality education and housing, and lack of access to basic health care. In our journey to wholly adapt an anti-racism mindset, our health equity team partnered with University of New Mexico to facilitate workshops, bringing together community partners and state employees to practice strategies for accountability. Accountability to us starts with dialogue with and not to communities that we serve. So in the images on the screen, you see that this group in the workshop brainstormed strategies to confront micro and macro aggressions, or just plain aggressions in the workplace. Strategies such as call in and call out are built in to make sure that we continue to address grievance, conflict, to make sure that we have accountability when we see discrimination. How can we act as members of communities to address it and to ensure that we build step towards anti-racism, towards health equity for all. In 2021, New Mexico Governor Michelle Lujan Grisham issued an executive order requiring state agency to collect sexual orientation and gender identity data wherever demographic data are collected. So this heralded an era where queer communities are included in CLAS standards as well. We work on improving culturally and linguistically appropriate services for folks in queer communities. So as a final highlight, I'd like to take you all as learners of a course the Office of Health Equity at New Mexico Department of Health launched last year, and it is called Gender Affirming Conversations at New Mexico Department of Health. So imagine you are at a public health office waiting for a routine transaction, and clients are waiting outside your office, waiting in the common area there. So a public health clerk walks out to invite a client with the name on the intake form, Albert Kim, into the room. So how should this clerk call out to the room? So learners are walked through two scenarios. You can see scenario one on the screen where the clerk says, "Mr. Albert Kim, please come in." But then the scenario then reveals that it turns out that Albert Kim is the birth name given to Esther, a young woman, a young transgender woman. Here she is referred to by the wrong pronoun, Mr. And when she stands up to follow you into the room, she's inadvertently outed to the room as a transgender person. Being misgendered can lead to a deep sense of shame and loss of self-esteem. It can even lead to harassment and discrimination. This young woman may not want to come back to the public health office and may be feeling unsafe now that other people know that she's transgender. In fact, according to the 2015 National Transgender Discrimination Survey, in New Mexico, 34% of survey respondents did not see a doctor when they needed to because of fear of being mistreated as a transgender person. So the training then leads to the scenario number two, where the better way to call out to the room is actually, I'm looking for Esther. How does the clerk know that? Because in the intake form, it is required that state public health offices give the client an opportunity to self-identify their gender identity, their preferred name, even though it takes a lot of bureaucratic improvement in order to change intake forms. It is time and effort well spent. Will help communicate to Esther that she can be comfortable and trusting that she is receiving the best care possible. So at New Mexico Department of Health, culturally and linguistically appropriate services and mindset help us align actions to address structural racism, discrimination, and instead move towards sustaining health equity for all. Thank you for your time and attention. I look forward to our colleague who is going to be the next presenter. I'm going to pass it back to Juliet.
Thank you so much, BC, for all of the wonderful information that you shared and for your commitment to communities in New Mexico. So it is my pleasure now to introduce our final presenters for today, Amanda Kay and Zelina Abner-Green from Seattle and King County Public Health, who is a grantee in OMH's Advancing Health Literacy to Enhance Equitable Community Responses to COVID-19 initiative. Amanda has been living in the Pacific Northwest for a long time, but still considers herself a Midwesterner. Growing up in Chicagoland, she discovered her passion for community engagement at age 13 by staging a walkout of her 8th grade class to protest the first Gulf War. And since that time, she's advocated for community public health, focused on transportation, access to green spaces, civic engagement, language access, and health literacy. She has one son who's 14, a lovely supportive partner, a cat named Nora Borealis, and loves to play disc golf. And with Amanda, we're pleased to have Zelina. Originally from Los Angeles, California, Zelina received her BS in public health with a concentration in community health. In addition, she studied in British Columbia and graduated with a master's in public health with a concentration in human design. She's passionate about, she's a passionate public health professional that's focused on racial and social justice, organizational change, and co-designing with the community. When she takes breaks from the cause, she enjoys camping, traveling, music, and social events, and trying new foods. She currently resides in Algona with her husband and their 3 kitties, Vader, Cleo, and Gizmo. And they're also expecting their first baby in July 2023. So congratulations to you and your family, Zelina. And now it's my pleasure to turn it over to you and Amanda.
Hi, everybody. Thank you so much for being here today and listening to what we have to say. I wanted to talk a little bit about our King County Public Health Language Access Program. This came about because of the COVID pandemic. So before the COVID pandemic, there was no centralized service for language access in King County Public Health. We knew that in order to be responsive to the very diverse communities that we have here in King County, we needed to act fast. So what we did is we created a program that utilizes community-based translators and interpreters to provide services for the residents of King County. This particular way of doing things lifts up our communities to be able to transliterate. It affects local conditions, so localization of the language. And it also provides a source of income for the folks who live here in King County. We believe as principal standards that language access services are equity in action. We often say it the lowest hanging fruit on the tree of equity. Language access builds bridges between equity, belonging, and enfranchisement. It makes everybody feel welcome when they can see something in their own language. Community-based language access programs provide meaningful, timely, culturally responsive, and accurate information to communities in King County. We also focus on organizational health literacy. We feel that we have a responsibility as an organization to improve the way that we are communicating with community in a way that they can understand better. Zelina will talk a little bit more about that in just a minute. King County is fairly diverse. In 2018, we had a population of just over 2 million folks. Our King County people of color rate is 28.7%. Foreign-born is 20.3%. And people who speak a language other than English at home is about 25.5%. Our feeling with our program is that we were able to really affect the way that people were getting information during COVID. So we translated COVID information into upwards of 40 languages consistently. We were using community folks, so we were really getting good localized resonating documents. And for us, we really feel like our vaccination rates show that. And so for us, we had a over 80% success rate in getting 85% of the primary series. And our COVID deaths were fairly low because people understood why they needed to wear a mask, why they needed to protect themselves and others. This is how we approach language access. We start in the middle by saying that it's equity, belonging, and enfranchisement. And that language access is not just translating documents or interpreting, but we also need to meet people where they are. So making sure that we're creating materials that people can understand. Maybe we're creating videos. We also work with a network of community navigators who would take our translated messages and bring them to community, talk to community in language, and then create a feedback loop so that the community would let us know what things they needed to know about. And that created a way for us to go and be more expansive with our outreach. So we were able to talk more about long COVID when that was necessary. We also focus on health literacy and plain language. We co-create and trans-create with community. So our network of community language service providers are providing real-time feedback on how materials are being created. And we also partner with ethnic media. I'm going to pass it over to Zelina Abner-Green now, and Zelina is going to talk a little bit about our health literacy program. Thank you all so much.
Hi, everyone. Thanks, Amanda. I'm so happy to be in community with you all today. So yeah, let me talk about the health literacy training from this grant and so forth, right? So we started off co-designing with community, and you're probably asking, like, what do you mean by community? Well, we started working with 26 community-based organizations here within King County that represent Black, Indigenous, and people of color groups, as well as 2 federally qualified health centers. A lot of the feedback that I'm sure you guys have heard is that much of the time, community is brought at the end of a co-design process, but in reality, they should always be at the beginning. So that's what we were trying to do with this grant when we were building out this curriculum and this training. So I'm really, really psyched that it came out the way that it did. It took us about 1.5 years, and within that, right, we came out with 3 different modules. So really, our curriculum is focusing on organizational health literacy to improve COVID and other social detriments of health-related materials. Once again, if you guys are familiar with Healthy People, 2030 just came out, and they put up their different objectives. And in the past, they have always focused on personal health literacy. But now there's this understanding that it's not just personal, it's also organizational, right? Institutions are made up of people, us, right? And so it really starts with not just an upstream approach, but also a top-down approach. It's a collective effort. The training also focuses on connecting anti-racism and health literacy. Our first module is basically on connecting anti-racism, health literacy, and health equity. And we've gotten questions around, well, why are we talking about racism? Well, remind yourself, look at history, right? Racism is actually rooted in literacy, right? So all the many different communities that we're working with here, specifically here in King County, are affected by that. And so that's why it's important that we have a foundational module that goes through that first before we start diving into the different strategies of how to best health literate community practices, as well as culturally responsiveness. And then lastly, I want to mention as well, the training itself, it really does build on empathy. while giving practical strategies to improve organizational health literacy. Many of our activities that we have are circled around empathy. So we have role-playing scenarios, for example. We have case scenarios. What would you do in this situation, for example? You know, and I think what's also really interesting about the training and just the turnout that we had is we had people from all walks of life that came to our training. We had communication specialists. We had nurses, we had epidemiologists, for example. We had just people that are just on the back doing admin work, all various different things, because what we're trying to show is that health literacy is not just in this little box. It goes across the whole thing. So yeah, it's been a really, really great journey. And if you all are interested in connecting a little bit more and kind of hearing about like our co-design process and how we got to where we're at, you know, our different feedback loop processes and what we're doing, you know, to kind of progress this work further in the future, please reach out to me and Amanda, to our entire panelist team. Like, I'd love for us to be connected. Thank you. I'll go ahead and pass it back to Juliet.
Thank you so much, Amanda and Zelina, for sharing your knowledge and sharing about your great work in Seattle and King County. So a huge thank you to all of our presenters for taking the time to share your expertise with us today. We hope everyone who's joining us today were enlightened by the presentations and will find the information useful in the work that you do. So now we'll transition into our question and answer session. So again, I'd just like to remind folks to please submit your questions using the chat box. And then also want to remind folks that this session is being recorded, and that recording will be available on OMH's YouTube channel in the coming days. So we've had a few questions come in via the chat box that I'll start with here. The first question, I believe, popped up, Amanda, during your presentation. It's a clarifying question. How are you defining belonging?
Thank you so much for that question. So that's great. I don't think it's actually up to me to define what belonging means. In a way, it feels like, how do people feel like they are belonging? And in our purview, one of the things that we found is that when people were seeing information in their language, even if they necessarily couldn't read it, there's a lot of low literacy, like in the Khmer community, for instance, they would see that that was an important thing that King County Public Health was trying to say to their community. That creates a sense of belonging into how they are seen by public health. And we, in our purview, that was a really important aspect. Also, along with our community navigators and working with community directly. Again, it's thinking about, how do people feel connected to this, that it's not for somebody else, that they actually feel like this is something that is meant for them. Thanks.
Thanks very much, Amanda. We have a lot of interest around the resources that were shared today and specific questions in regard to the trainings that were shared. So one, if there's a link, BC, to the gender affirming conversation training, and then also for Zelina, if folks are able to see more about the health literacy training.
Yeah, there is a link, and it is on the learning management system called DRAIN. I bet people here are familiar with, folks here are familiar with DRAIN, and it's on New Mexico DRAIN. I wonder if I can send it to our webinar organizers, like and then we can send out that link as a follow-up to this webinar.
Thanks, BC. We will figure out a way to share that out. We have a question about partnerships with faith-based organizations. So the question is there an opportunity for a church health ministry to get involved by raising awareness in the community as to what people can expect in healthcare communications, health literacy, or any other appropriate areas? And is there anything else we can do?
Juliet, I'd be happy to take that question. So I think absolutely there's a role for faith-based organizations to participate in this process. Actually, just yesterday, I was in a public forum and someone from the faith-based community stood up and said, you know, hey, we are a tremendous resource in communities to get health education out to various, to various stakeholders. And often, someone commented on how often in the congregation there are medical professionals. There's, there may be, for example, a nurse someone described an example of a nurse in their congregation that's helping to get information out. So from a CMS perspective, our office doesn't have specific information packaged for faith-based organizations, but all of that information that I discussed today is accessible to anyone who's wanting to learn more about CLAS and how it can be implemented. But we're also happy to explore what we may be able to provide as an agency. So I'd be interested to hear how other panelists engage faith-based communities in this work, but absolutely there's a role that everyone can play. And I think faith-based organizations are an important part of that as well. Thank you.
Thank you, LaShawn. Amanda, Zelina, or BC, did you have anything to add? Okay, we can move on to the next question, which I think is a really great question that we'd love to hear from each panelist about your perspective. What are the biggest barriers and what have you found to be most helpful to fulfilling your missions?
I'd love to take a stab at this question, this awesome question, Juliet. This is BC from New Mexico Department of Health, and I think the biggest barrier would be secured and sustaining long-term funding for interpreting and translating services for the trainings that the cultural humility that we need in order to serve our communities both in the public health track and in the clinical offices, and so that requires leadership buy-in, to work at the policy level, to work during legislative sessions, to get testimonies, to really make sure that we always have this funding that can be, sometimes the funding that is provided can expire in 2 years, 3 years, and with the changes and revolving door in leadership and the managers, we can see that goes out with the change in the changing of guards as well. So I think in New Mexico as an employee, to see that my cabinet secretaries are working on declaring structural racism as a public health crisis, and not just a declaration, but also to make sure to secure funding for a racial equity plan that includes language access and culturally appropriate services. From that declaration is super fulfilling for me to see the problems addressed at the root cause. Thank you.
This is Amanda. I would echo everything that BC just said. Our barriers are very similar. We're very steeped in and structural racism here at the county. And even when we don't think it's there, it's actually there. It comes in terms of, contracting or the way that we are putting terms and conditions into things. So our biggest barriers have been around getting buy-in. And one of our strategies is to really, and Delina touched on this, is to use empathy to kind of change hearts and minds and put people in the shoes of folks who speak language other than English at home or have disabilities, and able to kind of see why we do this, and that it is not a matter of it's nice to have, but that it is necessary in order to really move the needle on equity. We also declared racism as a public health crisis, and we are working actively to define what that is and to define strategies that will move those indicators towards being a more anti-racist organization. I don't know, Zelina, if you wanted to add anything there.
Nope, you got it, Amanda. Thank you.
Thank you, BC and Amanda. LaShawn, anything to add there from a federal perspective?
Are you able to hear me? Sorry, I was having a minute. So in terms of barriers, our office has a unique position within CMS. We work across all of the centers and offices within our agency that oversee the execution of Medicare, Medicaid, the marketplace, and CHIP. And as you all know, there is a focus of the entire federal government on how do we deliver equitable services and benefits, or how do we deliver our services and benefits in an equitable way. And as a part of this massive effort that is underway across the entire federal government, education on what all of these things mean has been an incredible part of this journey. And so, for example, for many in this space that have worked in health equity for a number of years, they may be familiar with CLAS standards and what that means and how they're implemented. But when you think about as a federal institution, not everyone that is engaged in this area or engaged in policy for this type of agency may be familiar with it. So what our office has done to try and address some of that from a barrier of one, increasing knowledge of this and then application to policy is we've had to do a lot of internal education across our agency. We have a health equity technical support program within CMS wherein we work with our components and partner with them as they develop policies that will have an impact on the healthcare system. And so some of what I talked about earlier of the recent announcement that we made relating to MA plans, it was a part of work that we've done in partnership with our components across CMS. So, from our office's role of operationalizing health equity within CMS, it has been, I think, the barrier to us doing this work successfully has been, how do you bring along an institution? And so that's been a part of some of what we've worked through. But I'm very excited, as as I mentioned, there are some important changes that are happening within our policy work, and it, but it starts with ensuring people have the information so that they can they can develop policy that will have an impact. Thank you.
Thank you, LaShawn, and thank you to all the participants for all of the wonderful questions that have been coming through the chat box. I see there's been a couple of questions related to data, and as we know, data is a really foundational pillar in doing health equity work. So I'm just going to try to couple a few of them together. What are the challenges that have been faced when it comes to data collection? And how can organizations be encouraged to look at their internal data on patients by primary language as one factor?
Sorry, Juliet, would you mind repeating the question? I think I think this relates to the sexual orientation and gender identity data collection, but I may be wrong.
Yeah, no problem. Glad to repeat it. So I think generally, what challenges are there when it comes to data collection from where you sit at the state or county level or at the federal level? And then a specific question about how can we encourage institutions to look at their internal data on patients by primary language?
So I'm happy to get us started on that. I mentioned our health equity framework that CMS released last year, and this framework is evidence-driven and stakeholder informed. And one of the number one things we've heard over the years from our stakeholders is they want to see, they want to see a greater focus on the data that we collect. And so we actually last year released a white paper that outlined some of the opportunities and challenges for CMS as an agency in the data that we're collecting. It's important. We have a lot of data on a lot of different populations, but we still don't have data on everyone that we need data for to make the best interventions and policy choices. And I'll give you an example of some of the things that we're moving forward that has an impact in this space. In FY 2020 prospective payment system rules for the post-acute care setting, CMS was able to add 7 standardized patient assessment data elements to our patient assessment tools related to demographic and SDOH data. And so through this rule, we are now able to collect race, ethnicity, preferred language, need for interpreter, health literacy, transportation, and social isolation for the first time. And this new data collection functionality will give CMS and our stakeholders the ability to tailor programs and policies in the post-acute care setting based on the needs and the disparities. And so, that one opportunity there, although it's not as broad as we would like to see it, is progress in us being able to understand at least a segment of those we serve as an agency, so we can better develop solutions to specific areas. So I think I'm answering the first question, but happy to see if my panelists have any other comments.
Thank you. I think for us over here, data collection has been really difficult. And the reason is because, again, when we're thinking about language access, the impacts can be wide. So if someone is reading information in their language and they go and they choose to get the vaccine because they were able to get it in their language, we don't really have a good mechanism to show that that is the connection, right? It's almost like sometimes data gets used to justify to do things. And our feeling is by having such high vaccination rates, we're really looking at that as a testament to the work that we did in language and the testament of the work that we did with community navigators to work in language. People were able to understand what it is that they were being asked to do. So it's a little harder. We found it a little harder to find a data collection tool that kind of bolsters that. So if anybody has one, I would be more than happy to hear about it and use it. Thanks.
Me too, Amanda, me too. This is Lucy from New Mexico here, and I think I can echo Dr. McCleaver and Amanda's point in challenges in data collection. I think in New Mexico's collecting data and using it and to using them to learn to with integrity and then strategize to help communities is the focus. But sometimes it can there is a micro level of like, how can we train our data collector to create a safe environment? Number one. Number two is when we get the data, how do we make sure in data governance process to make sure that the data can be readily available for community organizations based who live and work with the communities to utilize the data to then work on their strength, utilize their strength to then address the problem at hand. And so those are the two things that they're there are big challenges, but also I think very rewarding challenges to work on.
Thank you so much, LaShawn, Amanda, and BC for your insights on this question. Unfortunately, we've reached the end of our hour, so I just want to thank everyone for all of their questions. Thank you for your participation today and for a great discussion. I again invite you to check out our OMH website and social media accounts and subscribe to our newsletter for more information about National Minority Health Month and other resources. Want to also put a plug in for an OMH Facebook Live event that will be held on April 27th at 4 p.m. and feature the work of our National COVID-19 Resiliency Network. So with that, I thank you again. A very special thanks to all of our panelists for sharing your knowledge today. Hope everyone has a great rest of the day and weekend.
Thank you all so much for having me.
Thank you.
Thank you. Have a great weekend.